Welcome everybody today, October the 5th, to our next in the series of the Can Do Chameleons. We are so delighted to have these outstanding people addressing you today in our series. And let me just give you a few words about who I am and my co-presenter, whose name is Rethabile Moretsela, and who is an undergraduate student in the BSc in Health System Science. Today, we have our second in the Wits Can Do Chameleons podcast series for 2022. This series is a follow-on from our previous two during the pandemic years, and it seeks to address future directions for health system science graduates, as well as imminent opportunities that are arising even in these challenging times from ongoing health system policy reform and from efforts to provide better infrastructure and quality care. As we all know, chameleons have a unique ability. They are able to change their appearances to match their environments so that they can blend in and camouflage and adapt. This week's session is titled, Giving Health Leadership a Good Name, with a question mark. As we all know, leadership is a key element of strong, responsive, and resilient health systems. And it is so vital that South Africa nurtures and sustains health leaders who can work strategically within their portfolios and across silos. Legal cases, commissions of inquiry concerning serious challenges in health leadership, and countless other challenges have filled our news media of late, and they really demand our serious engagement. Well, in this session, we are drawing on the energy, the vision, and the leadership of innovative and compelling health leaders. The second of our presenters will be introduced just now by Rethabile, but let me tell you a little bit about our first presenter, Dr. Dulcie Rakumakoa, who prefers to go by the plural pronoun. Dr. Rakumakoa obtained their MBBCH degree from our very own Wits University. Welcome today. We are so delighted to have you here and inspired by you. They hold a diploma in occupational health, a diploma in HIV management, in travel medicine, a certificate, a master's of science in sports medicine, and a master's in business administration degree from Gibbs. Dr. Rakumakoa is what we would call, and what I think they call themselves too, a social entrepreneur, with a passion for providing affordable healthcare and wellness solutions for South Africa. Starting as a sole general practitioner in Vryburg 19 years ago in 2002, actually 20 years ago, they then co-founded UCare Medical Centres a couple of years later. QuadCare was then born just before the pandemic in 2019. And in addition to many of the services that these entities that you have initiated and provided, you also make commentary and offer leadership in the public domain. You contribute weekly to the Citizen newspaper and Borna magazine. In 2016, you were recognized by receiving a Social Entrepreneurship Regional Business Achiever Award. And in 2020, in a crowning achievement, you were named Queer Warrior, Suntown Woman of the Future, and you also got the Feather Award for the Role Model of the Year. We are absolutely honored to have your presence here today and to listen to you carefully as you give us of your wisdom and experience in the last 20 years and more. Over to you, Dr. Ramakoa.
All right, thank you so much, Catherine. I really appreciate the introduction, but I think I'm more excited also to be invited by my alma mater to speak on health leadership. You know, it's a big question. Like, you know, it has a question mark at the end saying giving health leadership a good name, and to be asked to speak at Wits, you know, about this, I find it quite a validation. You know, a validation of the work that I've been doing in the last 20 years since I graduated. You know, I remain very passionate about healthcare and healthcare for our people in this country, you know, and very excited to have this conversation. So maybe let me go into why I went into medicine in the first place. So when I was 6 years old, growing up in Hammanskraal in a township called Temba, we only had one GP in our township, Dr. Van Wyk. And I was with my grandmother in the queue. The queue was very long, you know, so my grandmother liked saying to me, you need to grow up and become a doctor so that you can treat me at home. I don't have to stand in these long queues, you know. So I knew from when I was 6 years old that I'm going to become a doctor for my grandmother. You know, I was not thinking of anyone else, just my grandmother, you know. So after I graduated at Wits, I did my internship at Klerksdorp Hospital. And then I did my community service at Vryburg Hospital, a hospital called Khanyisa in a village just outside Vryburg. And I think that hospital reminded me of my conversation with my grandmother, because yeah, I realized at that point that my grandmother's story was the story of grandmothers across the country, and where's like grandmothers in rural areas. So I decided at that time that immediately after my community service, I'm going to open a medical practice in Vryburg and treat the community there and provide affordable healthcare. You know, I was not thinking in business ways. You know, I was not thinking of setting up a social enterprise or anything like that. I just thought the people here need healthcare. I'm going to set up and provide this healthcare, you know, to just reduce the burden that Khanyisa Hospital was facing. It was a 60-bed hospital, which was meant to cater for 20 villages. You know, so you can imagine from infant mortality to, you know, complicated cases that needed to be transferred to Klerksdorp Mafikeng, which were like 4 hours away. You know, so I thought if we can do primary health properly in a place like this, we reduce the number of people that need to be hospitalized. Therefore, you know, you have less people needing tertiary health care, and the community benefits from it. So while working in Vryburg, I got exposed to the effects of the migrant labor system, because a place like Vryburg has no like sources of employment. So people who are employed, who are staying in Vryburg, have to be in Rustenburg, have to be in Carletonville, have to be in the mining towns, you know, to be able to access employment. Those are the men mostly that will then come home 2-3 years later with chronic lung conditions, with HIV, with tuberculosis, and then they become the burden of the communities in which they are coming from. You know, so I started now thinking, how do we make like this healthcare even accessible to other places that have an impact on this village? Because now you have a village that is suffering the consequences of mining that's happening 600-700 kilometers away from them, you know, because people have to leave those places and work in places like Vryburg and Carletonville. So then I came back to Wits and studied occupational health and opened my second medical practice in Carletonville. So with that occupational health diploma, I could get some occupational health contracts, you know, in the mines and small industries in the area, while providing the primary health care, you know, in the practices, and started bringing other doctors into the practice, you know, to work with me. Another interesting thing that you learn when working in low-income communities or in rural communities, you realize that the barriers to accessing healthcare are not just costs and proximity. It's also provider attitudes, especially for people who are different to what is the norm. Like case in point here being LGBTIAQ plus people, because I'm a member of the community myself. I saw that I was starting to attract a lot of queer patients into my practice, and they would tell me their experiences in the hospitals and the clinics and why they would prefer coming to me, because they felt that the practice was a safe space for them. So like the business started, like, like it was a business of healthcare that was just started, and the community kind of started shaping it because the needs of the community were so vast, and different, and things that we don't normally think about. Also as medical students, we don't get that much exposure to like assisting people who are different to us, people who hold different beliefs to us. Like if you look at the South African Constitution, we have the best constitution in the world when it comes to people being able to supposed to get access, to healthcare. But the realities on the ground are very different. We tend as a community to allow our medical practitioners to have prejudices, prejudices that will make them choose to treat other people and not treat other people, So what I started to do to show that the practices were safe spaces for everyone, including, like, more especially the LGBTI, I started putting the LGBTI flag at the corner of each practice, because that flag is obvious to everyone who is queer. If you walk past, even if a car drives past me and I see that flag, I will know that the person who's driving that car is queer, So it was that type of thinking to say, even if you don't know me and you walk past, see that flag and know that this place is a safe space for everyone, And what I've learned also is that when you create a safe space for the vulnerable, you create a safe space for everyone. You're not doing anyone special favors by being safe space for vulnerable, but by doing that, you are saying to the rest of the community, oh, okay, if those people are treated like this in this space, it means even me with HIV, I will not be, ridiculed. I will be taken care of. Even if I'm a teenage and I'm pregnant and I need a termination, I may be treated safely in a place like that, So it was like growth and shaping of the medical practice, at that time, and realizing that I probably this impact is needed across the country, because with the advent of social media, you started hearing people's experiences in other places, and everyone on Facebook would say, hey, when are you coming to, we've heard what you are doing in that place, when are you coming to our place, things like that. And then I went on to do an MBA at Gibbs. After doing the MBA, I traveled to India. That's where I learned what social entrepreneurship was really about, especially in healthcare. You had the Narayan Eye Hospital in India, for instance, that provides private ophthalmology care, but so affordable, even the poor people can access it, because of the different models that they were putting in place. So we started thinking after the MBA, how do we do that for primary healthcare, in this country? So and I became quite vocal then in the social media about access to healthcare and why everyone deserves access to healthcare. And when everyone can access healthcare, their country is a better place, So the first investor that I attracted was a guy called Pascal Frolicher, who was, from Switzerland, who saw my story on Facebook and said, I am coming to join you and work with you. So that's when we started UK, and we had a network of 3 medical centers at the time, the biggest one being inside Park Station. And I think 2-3 years after that, we were then approached by a consortium of investors, guys who are really also passionate about the country, but they are in different industries. We had actuaries, a consortium of actuaries and chartered accountants and people who are in the retail space, saying, how do we collaborate with you, to make sure that the country, can experience this level of healthcare that you're talking about and that you are providing in your 3 practices. So since the guys joined, we are now at 12 medical practices. We have 10 in Gauteng, 1 in Limpopo, and 1 in Mpumalanga. We have 4 medical doctors that work with us. We have clinical associates, we have nurses. We have formed this primary healthcare model where there is like in our model, we talk of task shifting, meaning, that can be attended to by a nurse is attended by a nurse, then a clinical associate, and then what needs to be seen by a doctor is seen by a doctor. We develop clinical protocols all the time. We have a clinical excellence manager to make sure that we are on top of our game when it comes, to making sure that we are not just talking clinical excellence. We are ensuring that our patients, are experiencing it. We have gone paperless, to make sure that there is proper record keeping, across the network, because that's one of the challenges in this country. And I think that's one of the things that will make even NHI difficult, just the medical records. Because if someone is in Pretoria and then they find themselves in Cape Town, there is no medical records. They have to start from scratch, So we thought, let's start thinking about what we want national health to look like and start implementing it in our own practices, so that by the time the country is ready to do it, we have been doing it for a while, and we can be contracted, to assist and speak to the decision makers to make sure that people can access, healthcare everywhere. And the use of technology also benefited us, during COVID, like at the height of COVID, when people could not travel to medical practices, we were providing virtual healthcare. And we were told that people in townships, will not are not keen on virtual healthcare, but we experienced something different, because people are on mobile phones. If we can consult them and email prescriptions to their pharmacies and they get their care, and those that we see that absolutely need to come in are the ones that we call in, so we were able to provide healthcare in that way. During the looting, 2 of the practices were completely looted out, but because of the electronic health records, we just had to replace the infrastructure, but the care could continue. People could go to our other clinics and continue receiving care, and that's how I really see that we have impacted the provision of healthcare in this country. At the moment, we see about across the network 4,000 patients a month, who are coming to us to receive, this care. And we can see the positive impact that the health education and the provision of healthcare is making in those communities, So another side thing that I'm doing is called QueerWell. QueerWell, it's an NGO that provides mental health care or access to mental health care for LGBTI. Because like I said earlier, Catherine, that the issue is normally not just cost and proximity to services. It's the provider attitudes, our practitioners sensitized, to deal with people who are different, to them. Like another thing that we do is trans healthcare, where we provide, hormones and monitoring of people's progress, who are transitioning. And I have found that with all the doctors and clinicians and nurses that enter, quad care, part of their induction is sensitization, because when you start asking people what's the difference between sex and gender and sexuality, you can you realize that people do not know what you're talking about. And these are like people that we send out into our communities to say, go out there and treat and provide healthcare to these communities. So I think the important question you asked me when we were preparing for this was, how can vets help? And I have thought about it, and I think this is where we start, the sensitization of our medical students, where we teach our medical students that the differences between sex and gender and sexuality, and how people will present, and the holistic care of patients, and asking pronouns, it's become quite fashionable now, to say like, what are your pronouns? But we don't realize how important and affirming it is, for a person who walks into your space and you say to them, hi, I am Catherine, and my pronouns are she, her. You have established the safety, for that person, because that person now realizes you're not just looking at me and decided, oh, she has boobs, she's a girl, I'm just going to call her she, because they could be coming to you because they are a trans man who's looking to transition. But when just teaching approaches like that, to our students, I think we would be creating future doctors of the future, doctors that are ready to be like model South African doctors. Yes. Thank you very much.
Wow, Dr. Darcy Rakumakoa, you have taken us on a journey. We have so many questions stacking up, and I'll ask the audience to scribble them down or memorize them, because we're going to go on another journey taken by Retabile, our colleague, and we're going to meet a young student leader on campus who I'm quite sure is also in accordance with many of your ideas. And then with your indulgence, if you can please keep on the journey with us. Yes, once they have completed their discussion, we're going to come back to you with some very interesting questions, I hope. So over to you, my colleague, Retabile. Retabile, we can't hear you because your mic is still turned off. And if you could just take a breath and start again. Thank you.
Good afternoon, everyone. My name is Imarazari Tawile, and I'm very honored to be part of this podcast. I've been assigned with the task to introduce the next speaker. So our next speaker is one of our own AVET students. It's Mapula Lehlogonolo Mohale, who is a final year student completing a BSc in Urban and Regional Planning at the University of Witwatersrand. As the current SRC Health Officer for the year 2021 and 2022. She has led various awareness campaigns, such as the Endometriosis Awareness Campaign, #EndPeriod-Poverty, Drive to Collect Sanitary Pads, and the MVETS Policy Awareness, also engaging with lectures to ensure that classes are inclusive and accommodating. She's also the current Public Relations Officer of Women to Women Organization, a former Gender and Transformational Officer of the School of Architecture and Planning, a former organizer of the VETS Economic Freedom Fighters Students Council. She's very participative, and I'm looking forward to hear from her. Over to you, Mapula Mohale.
Good afternoon, everyone. Thank you so much for having me, and thank you so much for the introduction. As she has said, my name is Mapula Lehlogonolo Mohale, and I'm the current SRC Health Officer. I'd also like to say thank you to the doctor for the insight that she has given us, and I understand where she's coming from in terms of healthcare. So as the SRC Health Officer, my duty is to be the connector between students and healthcare on campus. So by this means that I'm cutting barriers between students and receiving proper healthcare services on campus. So as you guys know, on campus, we have your CCDU, we have your campus health. And I think the challenges that we've had this year and before was the effectiveness of healthcare on campus. And we've seen the disconnect between students and campus health facilities. So my job is to be an activist and speak for those students that are not getting the assistance that they are seeking from the facilities. So over the past years, we've seen that the issues are mainly linked to the disconnection of health care on campus, which is campus health. So if you've ever been to campus health, you know that campus health is located below the matrix, right? Already that gives you an idea that maybe healthcare is not put in the forefront on campus. The fact that it's located below the matrix where it's kind of hidden, right? And our CCDU is on the other side of main campus, which is West Campus. And our main issue is that why isn't the school prioritizing health as they are prioritizing academia? Because the two have a link. If you have students who are mentally unstable, the performance will obviously be low. So we've had and faced the issue of fighting the system to ensure that at least students can get quality assistance, medical assistance, right? And unfortunately, right now, there's a bit of a crisis where we have a booking system that's taking place at Campus Health and stuff. But the people at Campus Health have actually worked very hard to ensure that students get care. And honestly, the school has also tried to fix the system. And I think that doesn't just go back to the system in our institution, but it goes to our healthcare system as a whole in our country. And we've seen how far it has failed us. And as the doctor said, that she decided to be a doctor because of the disadvantage that they were facing back in our community. So it brings back to us to say that maybe they're not prioritizing health at all. And it's up to us as citizens to actually take action and be activists and speak on health issues that people are facing. So in our generation, our biggest struggle with health is mental health. And we've seen that in the homes that we grew up in, a lot of us are not taught about mental health. And once you scream that you have depression or you have anxiety or something is going on, your parents will just tell you to pray or just, oh no, you're just acting up or anything like that. But there's not enough education around that. So when people come into a space like university, they're constantly triggered by people that they come across. So I think we still have a long way to go in terms of addressing health on campus, especially mental health, where we've seen an influx, especially after COVID. And the school has tried to have strategic policies to address mental health, but the issue with mental health is that not enough knowledge is being given to students, and as well as the background of what is causing those mental health issues is also not addressed. So with some of the students that I've spoken to, some of them have body issues, and those body issues later bring in a sense of insecurity. And that sense of insecurity later grows into you not believing in yourself and getting to a space where you feel like you don't even deserve to be in this world, where you go through a sense of depression. So I think the main issue is just as activists and leaders to bring in light to health issues that are happening in our spaces and even in our communities. So even with my SRC role, I was fortunate enough not to just keep it into the university space, but I also took it out into the community, where I was also empowering young girls on period poverty and confidence and your body image and mental health, just imparting a bit of knowledge into what health is and what assistance you can seek in different spaces. So yeah, I think those are like some of the things that I've been tackling this year. But all in all, with regards to the health system in South Africa, I believe that more can be done. And a lot of youngsters have shown great interest in healthcare. And I think within our university space, a lot can be done if we bridge the gap between your medical campus and main campus. There's quite a disconnect between medical students and activism. And by activism, I don't mean being in a political space, but being verbal about issues that students face with regards to healthcare and any sort of thing that is affecting the student populace. But a lot of people that I've engaged with from healthcare have said to me that they've got so much work that they don't have time to be activists. But I believe that even a small change would make a difference. And you don't have to go out and be at the top of the table to say that I'm an activist, but you can just be an activist by simply just speaking on issues, even if it's on your WhatsApp statuses or on your Instagram, just to bring in a bit of light onto what healthcare should be and how it should be shaped, even in our own institution. And I think that's where we should be starting to empower change, starting with our own institution and then taking it out into the world, because these are the people that are going to be the ones that are changing the world. So yeah, I think that's all I have to say. Thank you so much.
Thank you, Mapula. You've really said quite a mouthful. I was moved when you mentioned the way the campus is constructed, the way it doesn't favor health, when you mentioned the campus health and the CCDU and the places where they are located. And also when you mentioned the fact that our medical students, they are not more into activism, and because they complain about a lot of work academic wise. So you really said it quite full. I will hand over to my co-host, Catherine Benz. Over to you.
Yes, thank you so much for a challenging and thoughtful presentation. And in addition to making quite a lot of the work of your colleagues to bring truth to the space, and actually, I think, being very modest about the achievements that you have got going and the kind of energy that you've brought to being a student at this moment in this faculty at this time, and also outside of your university life to the community from which you come. And I wondered if we could kick off with the first question before we go and look at the question and answer space, which we will field in your direction, and actually get the two of you to talk to each other by passing the baton, if they wouldn't mind, back to Dr. Rakumakoa, and asking about if you can cast your mind back to when you were in the very position that our lovely colleague is sitting in right now and studying at Wits, and what was going through your mind then about health leadership, and whether or not at that point you would have had any conception of the kind of energy you've been able to build through teamwork and interprofessional work, or whether you felt yourself to be very isolated and struggling with, amongst many other things, your own journey around gender and finding yourself in your own space. Over to you, and I welcome the presenters and speakers to all open up their cameras while we have this conversation.
Thank you very much, Catherine, and thank you so much, Mapula, for your passion, and the difference that you're already making, in the world. You said two things that really struck a nerve with me, or struck a chord inside. Number one, you talked about the students being disconnected. You are right. It is an issue that, like, you have medical school there, and then commerce building there, and then engineering there, and because if you think about it, all problems that we have as a country or as a community, they need collective effort, to sort out. A lot of the other stuff that I had to learn later in life, like, for instance, when I did the MBA for the first time, I was exposed to economics. I was exposed to financial accounting, HR, marketing, topics that I had never had to think about as a medical student. And for me, I found it quite disturbing, for instance, that I never had to think about economics, but I'm trying to solve the health issues, of a country, and it's all about economics. People's ability to afford healthcare is all about economics. So I know that I probably would have been a better doctor earlier on had I had the opportunity to have conversations with my friends who were doing BCom, for instance. If you think of healthcare systems and information technology, if I was interacting with IT students and I said, like in a random conversation while we're having lunch, that imagine if there was a system that could do this, and one of them would say, hey, but if we put this and this together, we could probably come up with something. And these things could be happening now, actually, at university level, where students are just getting together across their disciplines and saying, guys, wait, how do we solve the energy crisis in this country? We don't have electricity. What engineering students, what are you thinking? And the finance students think, okay, how do we make sure this is financially feasible? When you put people across different disciplines together, the solutions are huge. Like, this country can be solved by just people coming from different disciplines coming together and thinking, sitting around the table and saying, here is a problem, how do we sort it out together, So I think make sure, like as students, make sure that you guys are having conversations about the country all the time, because, and you're right about activism. It's not about just like, jumping on top of tables and whatever. Activism is like putting a social media post about access, activism is having these conversations. Activism is saying, we don't want this situation anymore. How do we get together and make sure that it changes? So I think it would have been quite interesting to meet students like you when I was a student myself, where we could just sit and talk about how to make this country a better place. So thank you so much for your presentation.
Thank you so much. I would like to invite Mapula to come in and respond to you and challenge herself and you back. And while she's preparing to do that, Juliet Rondongo has been asking in the question and answer exactly into the space. She says, when I was a medical student, I didn't do activism because I assumed that activism, I presume in all the ways you're describing now, was against me as a future healthcare provider. That's a very interesting comment. But
Yes.
let's let Mapula back in.
Thank you so much, Doctor, for the response. I fully agree with you. I think from what we've seen in the past years, I think last year there was a competition that was run in the engineering faculty where students have to develop a software. And there was a student who developed an interesting software that spoke to diabetes. So where you can log into your sugar levels and stuff. And it shows that even with what we're studying, they're all connected, right? And it is important for us to find that connection and speak and engage on it, because right now we're moving towards the fourth IR, and we're actually in the fourth IR, and it's important that we understand how all of these coexist. So as someone who's doing town planning, urban and regional planning, I've had to understand that in my course, everything is interconnected. So I have to know everything about everything. And that's what led me to be interested in just about anything on campus. And that's why I'm saying there can't be a disconnection between academia and health, because without then we have no academics, because the people who are writing these papers, the people who are researchers, are people who are supposed to be at a stable mindset to actually give us proper information, right? So once we separate the two and we have someone who's suffering from health issues and they can no longer write these papers for us, then we no longer have academia anymore. So from what Doctor is also saying, I think that's what students actually needed to hear, that for you to be an activist, you need to be the loudest person in the room. And I think that's a misconception. Activist, you need to be all over the news or everywhere, and people need to know you. But with the small knowledge that you impart, it makes a huge difference, because once I say something to somebody, they will likely go say to somebody else. And before you know it, it'll be information that is spread across. So we must understand that with the small things that we say, they impart change. And it's important that when we have conversations, we actually make the most out of that conversation to at least know that when I leave there, I have said something that can bring a sustainable change. Thank you.
Thank you so much. Do either of you have any response to so many students, particularly in the health science faculty, who amplify what Mapula is saying, but take a slightly different twist on it too? And that is that their progress in their degree is endangered if they look outside of their space, not only in terms of time and meeting deadlines and keeping their grades up, but also perhaps more existentially, that there is something about themselves as a health professional that will come under question if they do that. Have you got any insight or wisdom for us, Dr. Rakomakua?
Yes, Catherine, we are not, like, we cannot be silos, like you cannot like be an island and say, I'm going to be here and ignore everything else. And then when I graduate, like then I will start engaging with issues, because the issues that are existing are the ones that are going to drive you, to find out more information, to want to learn more, so that you can make real difference, in your communities. And sometimes differences that people make start with the small communities that they are from. As a medical student, maybe just know the medical issues or the healthcare issues or the healthcare access issues in the small community that you come from, and that way you're going to start thinking about the world differently. And even your research, you'll start looking outside to see what are other countries doing. That is part of your learning, when you start thinking wider than just like, what is presented in front of you, and thinking of ways to apply what you are learning to make a difference in the community that you are from, because like people like gave the social entrepreneurship a name and say it's social entrepreneurship. But I believe that all of us, if we go into entrepreneurship, especially in South Africa, we become social entrepreneurs because we are solving community issues. Entrepreneurship is about identifying an issue and coming up with a solution for it. So we are all social entrepreneurs at the end of the day if we decide to go into private healthcare. And private healthcare is not just setting up a GP practice. I mean, Mapule was talking about someone who developed a software, that can track diabetes. That is revolutionary. That is providing healthcare access. That is making sure people know their healthcare status, all the time. Because a lot of, like, I remember we once in Park Station decided to set up a pop-up clinic, in the station, and just did free glucose checks to everyone who was walking past. We found on that one day about 34 people who had high blood sugar that were not aware. Like something like that makes it a huge difference, because probably more than half of them will go to their, to their doctor to now start checking and taking their treatment. So little things like that also students can start spending their time doing, just seeing what differences they can make in their own communities, because that is what's going to make them better doctors. Yes, the grades are great. When you come out, and you see your patient, they might not ask you how many marks you got in your anatomy exam, but they will care about how you approach them, how you treat them, and what difference you make in educating them. Because another thing is our people are not educated enough about their own illnesses. You do meet a lot of diabetics, hypertensives who do not know what a healthy diet looks like. Just starting to have conversations like that also within our own families, we impact communities, because then your mom goes to church and then she talks to other women in the church. That is how, we make sure that healthcare is accessible to our people all the time. So people should not see getting involved in these conversations as a deterrent to them, succeeding and becoming good doctors, because ultimately good doctors are people who are aware of the issues, healthcare issues of their communities, and making a difference in those.
That's such an exciting set of agendas that you put out for us. And we've got some questions that are responding to both of you, Mapule, and to Dr. Rakomakua, and challenging us even further. Daniela Hueman, one of our wonderful colleagues, asks, how can we create a university community culture that works to have these different faculties speaking to each other, working together around these sustainable development goals? Isn't it time for these kind of learning hubs, learning centers on each campus, kind of what Mapule is almost single-handedly trying to do in creating her own culture, and what you've sought since you graduated from WITS? I mean, it feels like in the last 20 years, Dr. Rakomakua, you've gone out there and you've kind of sourced and nourished that, even going so far as to travel to India to learn about how the social entrepreneurs in the health space work there.
Yes.
Maybe I could ask Mapule to come in for a minute, because she's right here on campus, and tell us if she sees spaces or openings where that could happen, either on the health science campus or others she's been on, and then also get you to reflect on back in the day when you were on the WITS campus.
Yes.
I think more workshops should be hosted. So During the course of this year, we've hosted a lot of health activations on the library rooms. And we've seen the response in students. A lot of students actually take interest and ask important questions when they come to these activations. And I think maybe the school should start having more workshops that bring in students together, similar to what they had with Entrepreneurship Day, a 5-day workshop where we bring in people from different faculties to speak on the different health issues that we're facing in South Africa and the solutions that we think could come from that. After all, our university prides itself in being the leading university. And I think it's a university that exists for ideas. And most of us have sustainable ideas that could actually change the world. So if the school could have more workshops that speak to finding solutions and creating innovative ways to tackle healthcare in South Africa, maybe then we can have a breakthrough of the health system in South Africa. But also, I just want to add something small from the previous speaker regarding health students. I think health students should also identify who they are outside of health as well, so that they grasp what type of doctor they want to be. So as Dr. said, she pioneers health issues that are linked to queer people, and that creates a safe space for queer people. And if you're going to be a doctor and maybe you have a spiritual calling and you want to pioneer African spirituality and being a traditional healer, then you can, and understand the type of doctor that you want to be in this space and to who you want to relate to. So it's important that we don't all choose to be the same, because once we are the same, we start thinking the same. And it means that we no longer have solutions, because we're all thinking like, I don't know, but we're all thinking in one straight line, and that creates a situation where no solutions can be created. So it's important that as a doctor and as just a student, you establish the type of student that you are and the changes that you wanna bring into your community, because there's life beyond university. Thank you.
Dr. Akumako, I see you nodding away. Would you like
Yes.
to come in here before we put the next questions to you?
Yeah, I find it interesting that it is possible to have these conversations on campus across disciplines, you know. So like my approach would be maybe through the SRC, we like you tabulate maybe top 10 issues in this country or top 10 problems in this country. And like students then come and like, you know, they sit in their little circles, you know, across one issue. And we say it does not matter what field you are from or what you are studying, just come through and let's talk about how we can tackle this problem. There will be a different level of thinking, you know, because like, you know, even if it's a health problem, like I said earlier, you know, there is an engineering solution to it. There is a finance solution to it. There is an IT solution to it, you know, operations, logistics, all those things, you know. So like, I think we just need to identify problems and give the young people free rein to talk about them, you know.
This is so exciting.
It is like, yeah, it is exciting, because for me, I watch, you know, across the social networks, like, you know, the different conversations that happen. And at some point I used to think young people have no interest in this country, you know. But like the more you listen and recognize where they are coming from, like, you know, like in a non-judgmental way, you get really like great insights and different ways of thinking in things that, like, you know, I myself would have not thought of, you know, like you get from young people, and it's really quite interesting. So we just need to put the problems in front of them and step away and just listen.
And of course, then I think that you will probably take this, I hope, as a strong compliment, listening to people such as yourself and Mapula, who each in your own way, I mean, obviously you are 20 years since graduation, have actually created something that didn't exist before, have created a network and an awareness, and in your case, a truly extraordinary set of resources. This is enormously nourishing to people's resilience and their morale and their sense of purpose. So
Yes.
we've got a kind of second question coming from Daniela. But before we go to that, I think it would be really interesting for Retabile to put her question, which is also the question of a lot of health system science students, to you. Over to you, Retabile, and then we'll go back to a subsidiary question from Daniela.
Thank you. So my question is basically about the national health system. So with the current state of South African health system, how well will the implementation of the national health insurance bridge the gap between the public and private healthcare centers?
Okay, I'm guessing this question is towards me, Neritabil. Okay,
Yes.
all right. Firstly, like, you know, in theory, like on paper, everything looks great. You know, everything always looks great, you know, on paper. You have private healthcare system that is thriving and doing well, but it's highly inaccessible to a lot of South Africans. You know, people who are not on medical aid cannot access this private healthcare system. And that's where people get what is called the best care, you know, and then you have a overburdened public health care system in terms of our hospitals and clinics, and staff is not motivated and fatigued, and there is lack of resources, you know, so the NHI is meant to bridge this gap. You know, the NHI is supposed to be kind of the medical aid of communities that cannot afford medical aid, you know, meaning now these people can, like people can now be able to access what would traditionally have been private healthcare system, you know, through this national health insurance. But now you need the buy-in of the private healthcare players who've always gotten away with the charging of exorbitant prices and what's the model, like a fee per patient type model, where the NHI is coming and saying, take care of a community and let's pay you for a community. So there is a lot of resistance from that side, because now it affects people's pockets, you know. So that is the difficulty. And I think that is one of the things that has delayed so much the implementation of the NHI. So now you have players like ourselves who are social entrepreneurs who are coming in at exactly that gap, you know, that, like, you know, where you said, like where I said, people cannot, like we have made the healthcare affordable, and our role, I see it as making sure that this model is sustainable, because if we can prove sustainability with this model, you know, then we become a perfect partner, so to speak, you know, for the government in implementing the NHI, because we would have been charging these lower prices and providing the same level and quality of healthcare that people are getting from the existing private healthcare system. So it is work in progress. It is difficult. It is doable, but it needs all the sectors, you know, to really want it to work.
Yeah, this is a very exciting answer. Retabile, have you got any comeback question there? Because this goes right at the very heart of what you and your colleagues are working on.
Yeah, when she mentioned the fact of policy and policy implementation, and the idea of top-down approaches of policy. Sometimes there would be a policy good in theory, good written on paper, but then when it comes to implementation, there'll be problems, because I remember we did a research in one of the papers we did in my academics. So we found out that like policymakers don't engage better with policy implementers. People who make policies don't go into the community and talk to the people who are in the community about the problems, for them to be able to implement the policies better. So there's a gap between policymakers and policy
implementers. Yeah.
Yes, yes.
No, that is a huge challenge, you know. And if that conversation can happen, I think we will have better results, you know, because the people who are on the ground are the most important, because they have been dealing with these issues. They know all the challenges, you know, it's not theoretical.
It's so interesting to hear the two of you have this discussion, and also think of what Mapule challenged us with. She said students shouldn't think of themselves in cookie cutter ways. Not everybody has to be the same kind of a nurse, the same kind of a doctor. In fact, we need to recognize our differences and have this respect and sense of perspective baked in. And she gave some brilliant examples. Well, this was also in some of your opening comments as you were setting out your biography and your journey, Dr. Rakumakoa. So here is a challenge that I know Retabile and myself and others think about a lot. I'm sure you two do too. And that is how, on the one hand, do we ensure that, for example, everybody knows about the Constitution of South Africa when they're at university, at the very least, if not more broadly. We understand issues of colonialism in our past, issues of race and class division, issues of political economy, issues of infrastructure and of access and of justice. And we also understand, for example, the complicated and very difficult but important to understand journey of sex versus gender identity. Let's say we expect that everybody who graduates from university should have these basics, in addition to, for example, being a town planner or a commercial science student or a health practitioner. How do we ensure these core curricula that we must all succeed in, and that we must be benchmarked by, so that we meet our peers in the country and the continent and internationally, but at the same time allow for difference, individual spirit, autonomy, and different forms of identity to thrive? Since this is what you've built your practice on, in a sense, putting the flag, the LGBTQI flag, outside your office, but at the same time using it as a way to invite all people in. Could you give us some of your wisdom here, please, especially thinking of us as an educational space and context?
Oh, that's a difficult one, eh? It's a difficult one too, because now you start thinking of the individual courses and where you place it. And do you place it in first year or in final year, or is it a component of each and every course? That is a difficult one, Catherine. And you also don't want to, like you say, compromise on the quality of the, like, you know, of the important academic outcomes that are wanted, you know, in terms of what caliber of graduates that do you produce, but also realizing that it is that caliber that is relevant to South Africa, that recognizes South Africa as it is, you know, and with all the people that are different in it. So this would need like proper workshop. This would be something that would need to be properly workshopped. I have no immediate answer to it.
I wish we had two of our seniors here with us today. Professor Mguni, who gave us his apologies, and he's the Assistant Dean of Teaching and Learning. You are speaking his very language, and he's working on workshops even as we speak. And he's in curriculum redesigning workshops along with people like Dr. Carol Hartman, Shiro Mach, and a whole range of other people, not only in UMI, but also in the new degrees. And we also have a huge spirit of entrepreneurship sweeping the campus at the moment with these hubs that are being created. So I'm going to share the recordings of this podcast with some of our seniors so that they can see that there's a ground up swell as well as a top down swell. And I really hope that when you come to visit us soon on our campus, let's give us at least a year or two that you can actually see the spirit of some of this palpable, and that people like Mapule are graduating into the space. But Retabile and her colleagues are not over with their questions yet, because we have, first of all, to return to a challenge by Daniela, which is a fascinating one. It goes back to who is our community when we're at the campus of WITS. Now, you've got Mapule, who's been working in the community from which she hails, as well as campus. You've got yourself with your childhood and your growing up and then returning and then observing the consequences of migrancy and thinking of yourself as being in two places at once. And you gave us a very detailed and very precise health reason about why you needed to address the effects of one place in the source of another, which I found very, very challenging and powerful. But we also have Daniela asking us this, and she doesn't hail from the Johannesburg area, but this is where she is now, one of our colleagues. She says, how can we do something like community-oriented primary healthcare research, which is sort of action research and learning, using WITS as a space to do it from? For example, Johannesburg is a great place where we have this huge homeless community who can benefit from this intersectoral work of social work, commerce, built environment, health sciences working together. So that's one question, how to use the campus itself as a space. And then I'm going to tag another one on and ask Mapule, and you first you, Dr. Akumakoa, and then Mapule to come in on it. The second one is Juliet Rundongo, who's been very animated all the way through the discussion. And she's agreeing with you. Yes, there are so many reasons why NHI has taken so long. The ones you list, funding, upscaling of hospitals and clinics to private levels, increases on taxation, questions about how government will utilize the money that the medical aids have got and such. We have other questions coming in for Save It. And I wanted to put specifically to you, Dr. Rakumakoa, how would you scale up? And can you scale up from this enormous establishment you've already created? You've got about 4,000 patients under your care in all of these different entities, including some that were burned down in July last year in KZN. And you told us very interestingly how the digital record keeping allowed you to continue point of care service to some of those people. But you've also described getting investment from social entrepreneurial investors from abroad. I think you said Sweden. So this is extremely intriguing. How would we take your model and scale it up? Do you have the capacity to do that personally? And then can you link that to some of the very challenging questions that Juliet asks? And then finally, can you come back to Daniela's questions about Johannesburg as an almost laboratory for our work?
Yeah.
And then when you've had a tackle at some of those challenges, maybe we can ask Mapule to come in as well. And then we'll round up with the last 2 or 3 questions. Over to you.
Sure. Okay. Where do I start? Okay. Joburg as a lab. I love that. They said, we have a homeless community. So if you think homeless community, the issues are vast and different, and they require different disciplines, you know, to address. And I think that would be a perfect case study, you know, where you take a couple of students from the different departments and say, let us go and visit the homeless, have a conversation, hear what the challenges are, and then come back together and start drafting, you know, solutions for the different issues. I think that is where you're going to see like the minds of the students really working, you know, to see how do we supply water to these guys? How do we supply electricity? How do we supply, you know, accommodation or places to stay? How do we make sure they can access healthcare? You know, all this different, how do we make sure there's proper record keeping and management in such a setting? You know, that I think that is a perfect laboratory to test this model of different disciplines coming together to solve a problem. Scaling up of quad care, that is the plan. You know, we are currently at 12 clinics. The plan is within the next 3 years, we should be at 30 clinics, you know, and we have crafted what we call clinic in a box, you know, in that, you know, we can just like, as soon as we identify a spot, we can have a clinic open within 2 weeks. You know, that is how well we have, you know, done this over this period of time since the investors have come in. It is at 30 clinics then that we will be looking out at more investors with even deeper pockets to see how we spread this, you know, across the country. So the model to scale up is there, it exists. We know, like, you know, what the staffing looks like, what the logistics looks like, you know, what the IT and all the elements that you need to be running a practice. So that is sorted. I don't know if I left any question.
I think you've been very comprehensive given our short time. And Mapule, yes, we're asking you to see what do you want to respond to in that menu of different issues. And we add one more to you, Mapule, from the questions. You know, how do we get firms in and around Johannesburg, thinking of the laboratory of the city in theme again, how do we get them to connect up with students such as yourselves? And how do you go out and call upon the capitalist entrepreneurial classes and the makers and the creatives around the city to connect with you? Would you like to come in on those points, Mapule? And then we'll have one last question coming from our co-host, Reta Bila.
Okay. I believe that each cause is designed to bring in a bit of community work. Each cause exists to address a community issue that we have, right? Which means that we have the aspect of actually assisting our communities, right? And bringing the community work. So I think in terms of bridging the gap and making sure that students go out and also assist community members, it would have to be a situation of how the school actually approaches students, because a lot of students are very disconnected, and a lot of students believe that the only reason they're in university is to pursue their studies and then they die, right? But if the school actually brings in the insights that there's more to just being in a university space, there's a part of networking, and there's a part of actually growing yourself and understanding the people that you'll be working with, right? And the people that you'll be working with are normal community members, which brings us back to the bottom-up approach, where you need to do participatory planning. That's what we call it in our field. So it is important that in each course, the school at least ensures that there's workshops, or not even workshops, but there's programs that speak to community work. Maybe they could make it a prerequisite that actually in each semester, a student must make sure that they do a bit of community work, just to get more insights on what's happening around their space and solutions that they can come up with. And then you asked about, the second question was related to how do we get people outside to assist, or funders? And with most of the time, there are people that are actually open, that will send you emails to say, oh, I can see that you're doing this initiative and we have interest in it and would like to assist you because it speaks to our politics or our activism. But sometimes, unfortunately, you'd have to fully go to those people and propose ideas to them and say to them, okay, as a student and as someone growing up in the community, I see that there's a lack in this and I'd like to volunteer, or I'd like to bring an insight onto it. And I hope you guys could assist me in bringing light to it. And most of the time, people are open to actually assisting. A lot of organizations that I've been to and I have spoken to, they actually are open to it. And I think maybe the issue is that they don't know the channels that they're supposed to use to get access to students. So maybe as students, we are the ones who are supposed to give them that connection with us. So through your SRC, through your school councils, through your head of schools, and that's how students are able to reach these people. And I've seen a lot of times students get these connections through programs that are hosted on campus. So you'd find that the faculty is hosting a program, so a program such as this one, where students would say, oh no, I have an interest in that doctor and I'd want to speak to them and give them information on what I've discovered and if they could assist me. So I think the more the school hosts more programs, the more assistance is coming in, and the more people are actually taking interest in being involved in our student populace as well.
Oh, it gives us such hope to listen to this. We have to wrap up this webinar, but it is almost impossible to, because the questions are pouring in thick and fast. Retabile has one that she's going to put to you, and then I just want to read out some of the blistering questions that we've allowed into the chat that are coming up. You won't be able to answer them, but it means that we end the webinar knowing we have to bring you both back. Retabile, can you ask your question, and then I'll read out the last ones, just for the record.
My last question is about the incoming health professionals that work in rural areas. Dr. Dulcie has mentioned that she worked in a rural area, and that doctors who are reluctant to work in public hospitals, especially in rural settlements, because they complain about the lack of resources. So I want to pose a question to Dr. Lucy as like, how did she deal with these challenges, and what advice would she give to an incoming health professional who's going to work at a rural settlement?
Yeah, so we are different, as people, as like, I was in a hospital like that I spoke about that had no resources. It was a 60-bed hospital to cater for 20 villages. So for me as an entrepreneur, I saw it as an opportunity to say, hey, I can do primary healthcare here so that less and less people need to be hospitalized. Because I have spoken to doctors who have said, I would never work in a setting like that, I would leave. I have had to approach doctors to come up with solutions to there's an ophthalmologist that I approached to see how we can make cataract surgery more accessible to people. And he blew me off because he said, why would I want to do that? You know, I'm not in the business of providing access to healthcare. I just want to see my few patients and make my money. So we are different, but these conversations need to happen so that more people like us, you know, can step up and say, hey, we want to make a difference. How do we join you? How do we work together to make a difference in our community? So you guys must never get tired of speaking about this in your different spaces, you know, because you will attract the right people. When your vision is clear, other people will gravitate, you know, towards it and want to make a difference too.
Well, I think you're inspiring us today. I'm sure Mapule's eyes are pinging away with thoughts. All of us are. I mean, this is the longest we've gone on for any of these webinars. We can't ask you to answer these questions. They are more like statements in a sense. Ketiwe Mdluli says, a question for you. With the NHI in the pipeline, how do we see the future of South African healthcare accommodating, on the one hand, a whole range of African beliefs around health, the body? We could go on, I'm sure Ketiwe could go on, and the LGBTQI community. How do we integrate these topics with our current teaching in our spaces? Nomonde says, look, I'm an advocate for reproductive health in my own hometown, alongside a former classmate, but we always have to feel we tread so carefully and our work is unwelcomed because of our population, which is targeting teenagers and bringing in teenagers. Besides doing more dialogue, how can we advocate to garner interest in this issue, to overcome barriers in our community to accepting teenagers and their sexual and reproductive health needs? And then I think on quite a high note, Rakiba Kasim ends by saying, listen, COPC is in fact best suited to Wit students due to the fact that a lot of the students, first years all the way to fourth years, were brought up and lived through the depths of COVID. And they've been at the very heart of community-based initiatives in their own families or communities. And so in a sense, I suppose what Rakiba is saying is, we've already got a community of practice, let's work with it. On behalf of everyone who joined the webinar today and all the people that will listen to this podcast in the months and years to come, please may I thank my co-host Retabile from the bottom of my heart, Mokule, for being a truly inspiring student to have on the campus. And last but not least at all, Dr. Delcy Rakumakoa, for your interest and for your passion today, and also to our wonderful technical team, Veshni, and all of my colleagues such as Andy, Dr. Partha, Dr. Sinatemba Makanya, Mr. Stephen Pence, our intern assistants, Christine and Simon, and everyone else that's helped with this podcast. Hopefully it will live on for years to come and continue to inspire us all. Thank you. It's not the last time we're speaking to the two of you. Thank you so much for your time.
Thank you so much for having us. Thank you.
Have a great afternoon.
Okay, you too. Bye.
Bye.